When I first met my wife, she rolled up, got out of bed, and took 2 steps, slammed sideways into the wall, fell onto her hands and knees, scrabbled to the bathroom and started being violently sick. And I thought, she's having a stroke. As she lies down, I can see her eyes spinning in her head. Unfortunately, I can recognize it straight away and say, okay, this is a dizziness condition caused by crystals in the ear area. So to see it in the moment, you realize just how scary that was, how horrible it was. It just really awakened a lot of sympathy for me and started really wanting to understand more about it and how do you help people with it.
What is it that you're doing different?
We're not just trying to say, I've done this examination, here's your diagnosis, good luck with that. We're trying to say, okay, what is the actual physiological process in place and what things can we do to influence it to make it better? I had a woman once, she refused to leave the house for 2 years, literally one treatment, gone.
You have an app.
Yeah, so the Well Balanced app. It's a vestibular rehab app, particularly focused on triple PD and vestibular migraine. So during COVID, no one could travel. I started doing video calls and I found that my Disney patients got better just as well as they did as if they saw me in person.
And success rate?
The vast majority by 12 weeks are doing fantastically.
Dr. Jake Cooke is a dizziness expert. And so if you're somebody that suffers with dizziness, whether that's spinning of the room, which is vertigo, or unsteadiness, or this rocking sensation, or you know somebody that's suffering with dizziness and it's been going on for a long time and not being able to find any solutions yet, then this is definitely the video for you, because Jake unpacks some of the most common types of dizziness and particularly focusing on those that are often overlooked. And we look at what they actually look like and how you can fix them. Jake has also, over the last few years, been developing an app to help people suffering from dizziness, and particularly those that are maybe not quite as commonly diagnosed. I hope you enjoyed this episode as much as I did. As usual, you can also watch these episodes on Spotify and Apple Podcasts. Let's get straight into it. Dr. Jake Cooke, can you start by telling us who you are and what you do?
So I'm a chiropractor with a special interest in neurology. So I'm a diplomate of the American Chiropractic Neurology Board. I have a master's in musculoskeletal neuroscience, and I'm the chairman for the European Academy of Chiropractic's neurology group. So I've been in neurology for quite a long time now. I basically qualified as a chiropractor and pretty quick jumped straight into it. So I think it's been about 15 years of taking it pretty seriously.
And you started with the chiropractic. Why go into neurology? Why did you need more?
Always loved it. It was always my best topic at university. And when I graduated, came out and went to a kind of a normal musculoskeletal practice. It was perfectly nice, but I found myself getting a bit bored and a bit fidgety about 2 years in. And fortunately for me, my colleague at the time was aware of Professor Carrick, who founded the Carrick Institute and really is you could probably crown him as the father of functional neurology, really bringing kind of what's in a textbook into real life. And fortunately, she was aware of him and knew he was coming to Amsterdam to teach. So I was living in the Netherlands. And so I contacted a colleague and said, hey, it meant to be good. Should we go? And we basically just sat in the back of this seminar, like a 3-day seminar, 95% of the stuff going over our heads, just looking at each other, just kind of raising our eyebrows from time to time, like, do you get that? But just could sense that was the right pathway. And it was kind of a ridiculous seminar. I used to be able to bring in real patients. So chiropractors from across the Netherlands would bring in patients that were like stuck, basically, had been to see everyone, not getting it better. And it was just ridiculous. It was like being at some kind of evangelical church. People would walk in, be wheeled in wheelchairs and then walk out. It was just insane. But the difference was you had someone explaining what his neurological exam was, what the diagnosis was, how it had been a misdiagnosis, and actually it was a condition that you could treat with non-invasive procedures. And so you could see these really profound changes in people. It was just phenomenal. So I remember getting back on the train at the end of the day, just kind of being sitting there a little bit in shock, just thinking, wow, that was just incredible. And then it was just a joke, really. It was a cloudy day. The clouds parted, this beam of light came down, and I thought, okay, if you wanted a sign that this is the right path, that's it. And then I got into it pretty dedicated. So I was fortunate then that I was didn't have any major commitments, didn't have my own clinic, didn't have a wife, kids, or anything like that. So I went to a 3-day seminar at least once a month, and every evening I was studying until I passed the board exams. It took me about 2 years to pass the board exams, and then haven't looked back.
So most people know neurology as being something that is quite medicalized. How does it differ from the neurology that you're actually talking about?
It's exactly the same. Exactly the same anatomy, exactly the same diagnosis. We're using all the stuff that neurology and neurologists are using as well. But you'll sometimes hear the term kind of applied neurology or clinical neurology or functional neurology. The idea is we're not just trying to say, I've done this examination, here's your diagnosis, good luck with that. We're trying to say, okay, what is the actual physiological process in place and what things can we do to influence it to make it better? So all these processes, nothing just happens, right? You've got this spectrum of health, and you're moving up towards peak health or down the other way towards disease. And so what we're trying to do is look at these things and say, where is the condition located? What's the process involved? And then what things can we do that are non-invasive to resolve them? Now, sometimes we'll absolutely be working with neurologists and more medical fields because these things are complicated, and you want to throw everything at it and not be too philosophical about being non-invasive about it. We want to just do whatever it takes to get the patient better.
What exactly does that look like in your day-to-day practice? So how did that change your practice from when you were an ordinary chiropractor to now being a chiropractor with functional neurology on top? What does that practically look like with your patients one-to-one?
If I give you an example, so let's say you have shoulder pain. As a chiropractor, I would obviously examine the shoulder, examine the neck and the spine and have a look at what the movement is like. And then we basically get a sense of what is hurting, why is it hurting, and what do we do about it. Neurology is exactly the same thing, but when I'm looking at the pain, I'm going to really try to get a sense of, is it just localized pain? Have you just got a local injury like a muscle strain? Or do I then, if I look at other parts of your body like your bicep, is that also just as tender? If I come down to your forearm, is that also tender? So we start to get a sense of, yes, you might have a local injury like a musculoskeletal injury, but that musculoskeletal injury can result in neurological changes. So now actually the pain can spread. So although it's not a nerve entrapment, you still get that referred pain into the arm. So many people have had the experience of saying, I had a whiplash, my neck was really bad, and then my shoulder started hurting, now my arm hurts, now my whole right side is always painful. So in neurology, we're not just saying, oh, you had a whiplash, let's just treat the neck. We're trying to say, let's understand that whole physiological process and try to move it back in the right direction.
So it's really more of a holistic approach than chiropractic already takes, isn't
Yeah,
it?
you're trying to take, the ultimate goal really is take all these systems and put them all together. So I think where a lot of people run into frustration is you see the cardiologist and he's only interested in the cardiology. And then when it's not cardiology, he's like, I don't know what it is, you need to see a neurologist. And the neurologist has a look and says, well, it's not neurological, you need to go and see an orthopedist. And the orthopedist, and you kind of go from one to the other. I think my ultimate goal is to be able to really understand the musculoskeletal system, the neurological system, the immune system, nutritional systems. The goal is eventually that you can see someone and almost see them in there as much as they're in entirety as you can, and see really where are the hot spots and what do you do about it.
One example I in regards to the mechanical side of the body where that really applies is it always baffles me how you can have a knee specialist, someone that only looks at the knee, when we know that the knee is controlled very much by the hip, by the back, by the ankle. And like 9 times out of 10 when I see a knee patient, often finding things across that whole chain. And so you kind of wonder, the patients start there wondering why is this treatment not working? I mean, occasionally it's just the knee, but I find that more often than not, it's not.
Yeah.
Which is very interesting. So you have a broad spectrum of neurology. Why have you taken more of a specialty into dizziness?
When I first met my wife, so I'm not very good at dates, so I'm going to take a stab and say 2015, we started dating. It was Valentine's Day. We've been dating for a couple of months. It was a lovely sunny day. We were lying in bed trying to decide what we'd do with the day. And she rolled up, got out of bed and took 2 steps, slammed sideways into the wall, fell onto her hands and knees, scrabbled to the bathroom and started being violently sick. And I already had all my neurology training and I thought, she's having a stroke. In your 30s, it can happen. This is awful. So poor thing, in between her being sick, there's me saying, can you say la, 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 ka, 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 pa, 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 put your finger to your nose. Can you do this finger tapping? So I'm trying to do this neurological exam while she's being sick in the toilet. She's sweating and she's shivering. She's telling me to go away, basically. Eventually I managed to get her back to the bed. And as she lies down, I can see her eyes spinning in her head, which is something called nystagmus. So as I lie her back on the bed, she gets nystagmus, which is where her eyes are kind of bouncing around in her head. Unfortunately, I can recognize it straight away and say, okay, this is a dizziness condition caused by crystals in the ear. So it's called BPPV. totally treatable, not a stroke, not dangerous. I can treat it now. So bless her, the treatment is, unfortunately you have to cause the dizziness to treat the dizziness. So bless her, despite the fact she's, panicky and sweating and tired, she lets me make her dizzy again by kind of rolling her head off the bed and make her sick again, unfortunately. We do the maneuver. She gets up. She's like, yeah, the dizziness is resolved, but she's absolutely exhausted. She literally slept all day on the sofa. Like, occasionally had a drink of water, occasionally went to the toilet, but otherwise basically lay with her eyes shut. It took her a whole week to be able to go back to work. So she started working from home, but she still felt so unsteady and so tired from that one really severe episode of vertigo that she didn't feel that she could get on the tube to go into central London. And it was such a real eye opener for me because I was already seeing dizziness patients. I was seeing BPPV very regularly, but I would always see them a few weeks later. So they can tell me it was really severe. I couldn't get out of bed. It was really scary, and I can sympathize with that, but I've not witnessed it. Whereas actually to see it in the moment, you realize just how scary that was, how horrible it was. It just really awakened a lot of sympathy for me and started really wanting to understand more about it and how do you help people with it, because it is really scary. You feel like you're dying. People give me the weirdest description. They feel like they're falling off the face of the earth. They have no idea where they are. They feel like they're having like a full-on panic attack. They don't know what's going on. So I started seeing more and more BPPV. And then, of course, as you start treating these things, you start seeing conditions that aren't that and wanting to understand more of it. So my vestibular migraine, for example, is extremely common. The first time I saw vestibular migraine, it wasn't how the textbook told me it should be. And then so you then go to the research and try to understand, hang on, my textbook, when I did the board exam, said it should be this very simple, you get dizzy for 20 minutes, then you develop a headache. Well, that's not how it presents. Some people might have that, but the vast majority, that's not how it presents. So started doing more and more research, and then, the better you get at treating it, the more patients you see. And that's kind of how it went.
And what's your impression of healthcare as a general at diagnosing and treating dizziness specifically, and particularly compared to other conditions?
The problem with dizziness is it's an umbrella term. So when we say I'm dizzy, you could be saying that I'm unsteady, that I just feel unsteady on my feet. I'm not controlling balance very well. You could be saying I'm lightheaded. I feel like I might faint. Or that you have a sense of vertigo, which is a sense of movement. So it's classically that you're spinning, but it might be that you feel like you're being pushed over or pushed down to the ground. So the problem is when people say they're dizzy, it could be a huge amount of things, and often it's dismissed. So often it's dismissed as anxiety or stress, or you haven't slept very well, or maybe you just need to drink more water. So a lot of people are walking around with dizziness, not actually aware they have a condition, just thinking, oh, I'm just a bit anxious. The classic one is people who go into the supermarket and get dizzy in the supermarket, hate being in there, feel like they're unsteady, they're going to fall over, just feel really anxious. And then they're told it's social anxiety because it's a busy space. So just don't go into them. And people start limiting their lives. So it is underserved, it's massively underdiagnosed and underappreciated by people who have it. So a lot of people don't even recognize they have it until they talk to me. And then I'm like, you have vestibular migraine. How long have you had that for? No. I don't get migraines. I don't get headaches. That's not part of the vestibular migraine. So they're different conditions.
Just wanted to stop the episode just for 1 second. If you are enjoying this episode, then please can you help me by hitting that subscribe button if you're watching on YouTube, or if you're watching on Spotify, then please hit that follow button. It really, really helps this show, helps me to make even better episodes and get better guests on. Thank you so much for watching. Let's get straight back to it. Yeah, good. And we'll get onto those more specifically, particularly the functional ones, I think, are a little bit more confusing, particularly in regards to the medical side of thing, the doctors, etc. And I think probably because they don't necessarily have the tools to look at it or fix it in the same way. They don't necessarily have the tools to look at and fix back pain like chiropractors do. You mentioned BPPV. Let's start there, because I think that's probably the more common one. A lot of people know what BPPV is, but for those that don't, can you explain what it is and what's happening in the brain?
Yeah. So benign paroxysmal positional vertigo, which is a tongue twister, which is why we shorted it down to BPPV. Incredibly common. It is a condition where in our inner ear we have these canals. So if you can imagine a rubber tube. We've got 3 of them that are kind of C-shaped, and in there there's fluid. That's how our brain works. So think of a compass, very similar idea that when I turn the compass to the right or left, it tells me which way I'm turning. Exactly the same with your inner ear. Now, just outside those canals, we have these little crystals that are used for weight. So basically what they're doing is sitting on a jelly, and that gives you a sense of weight. So when you're driving along and you go over a speed bump and you feel yourself kind of lift up, that's those little crystals lifting up. Just they're tiny, right? Tiny, tiny things. Yet these receptors are so sensitive. So you have this little sense of acceleration. Or when you're in a plane and it accelerates, you feel that acceleration. That's those crystals being pulled backwards. Now they are totally natural. We have to have them. But like all things in life, things can go wrong. The same way we shed skin, sometimes these crystals can shed as well. So they can break free from that kind of jelly, and they can sometimes fall into that canal. Now the problem is, imagine you had a perfectly smooth stream and I start throwing boulders into it. That stream starts to become a little bit more ripples, and then it starts to become faster, and then you start getting rapids. You go from grade 1, grade 2, and then it starts to become really like massive white water. It's exactly the same with these crystals. So when we drop one of them in, they're tiny, like tiny grain of sand, doesn't really have that much impact. But when we have more and more of them, the weight of those crystals starts to disrupt the fluid of movement. And now when I turn my head, rather than just having no sense of, your inner ear is like a silent sense. You don't really have any sense. I know my neck's turning, but my ear is not telling me 30 degrees to the left, 20 degrees to the right. When these crystals are in there, they disturb that the movement of that fluid. And so classically what happens is you'll turn, there'll be a couple of, a second or 2 seconds of nothing. And then that fluid, that white water smashes forward, and you really sense that have that feeling of dizziness. Classically, it's going to be in bed. So people lying in bed, rolling to the right, rolling to the left, and you'll know which ear it is. So if I roll to the right, I get really dizzy. It's your right ear. Roll to the left, I get really dizzy. It's my left ear. Now, there's 3 different canals and there's 3 different presentations, but there's too much for us to go into today. But the classic one would be, if you tip your head down and come back up, you get dizzy. If someone calls your name and you turn your head quickly, that will make you dizzy. It's going to resolve pretty quickly within seconds. So BPPV is intermittent dizziness. You move, it's positional, so it's always triggered by movement. I can't just sit here and suddenly get a BPPV attack. You'll hear that a lot from people. They'll say, I've had BPPV for 5 years, and it comes on, I can just be sitting there and suddenly get dizzy. Misdiagnosis. So BPPV is always, you turn your head, then you get dizziness. Classically, it's going to last 10, 15 seconds, potentially up to 30. In extreme cases, up to 60, but that's very unusual. You've got different varieties that might cause that 60 seconds. And it's horrible. You get nausea, vomiting, people get very scared, and people start limiting their movements. So they stop moving their neck. Part of the reason they start getting neck pain is now they know that when they turn their head, they get dizzy. So now they start moving like this, trying to avoid those quick head movements.
So they're moving their neck less, which means that you get more pain in the neck. Yeah. So it's essentially inner ear crystals moving, give you this sense of spinning, and it would never last pretty much longer than a minute.
Be really unusual. It really is often 10, 15 seconds. So it is a very short, brief period of vertigo. Initially, it can be very severe. It can be really horrible. But the brain is amazing at adapting. So if it doesn't get treated, you will say initially it's really awful, and then your brain should start to recalibrate and recognize that you've got a faulty canal in the ear. It will start to suppress that symptoms. So then people, if you see them in a month in, they'll often say, it was awful. Now I just know I have to move slowly. I don't roll to my right. They'll kind of find ways around it. The human body is amazing. People just find, without knowing anything about the condition, they know what triggers it. They know how to avoid it.
Yeah, the longer you have a condition, the better you can manage it yourself.
Yeah.
Okay, so that should give people a pretty good idea as to maybe whether they may have BPPV. If they do, it's relatively well fixable, isn't it?
Really easy. So if you think you might have it, the questions you need to ask yourself is there any hearing loss or tinnitus? So could you hear a ringing in your ear? Have you noticed your hearing on one side's dropped? If it has, go and speak to a professional. You need to get that looked at more because there's so many different conditions. BPPV, the treatment is called a repositioning maneuver. So the classic one, we've got 3 different canals. It's normally the posterior canal, and we use something called the Epley's maneuver. It's completely invasive and non-invasive. It takes a few minutes, so it's really easy. The problem is GPs are too busy to do it, so they'll often give you a sheet of paper. So a lot of people will go home with a sheet of paper and try to do it themselves. The research is clear. If you try to do it yourself, there's about a 30% success rate. And the reason is when you turn your head as you get dizzy, you don't like it, and you subconsciously move your head away from the position that you need to treat it. So if a professional does it for you, there's about an 80% chance they can resolve it in 1. Average number of treatments is 2. So often you'll go once, say, come have a great result from it, come back and say, the acute vertigo has stopped. I still feel a bit unsteady. On treatment number 2, fully resolved. often what happens is people are given a sheet of paper, they go home, weeks go by, and it's not having the right effect. So yes, you can treat it by yourself. There's loads of information on how to do it. I would often say get someone else to do it for you. So a partner to hold your head in the right position, a friend that you trust, and get it done properly.
And ideally find someone that actually treats it kind of more specifically.
Someone who knows it. There's lots of little variants to it. So sometimes I see people have got like a chronic form of it where it hasn't really resolved. That's because there's these different variants. So yes, the majority are quite easy, and most clinicians should be able to diagnose it and treat it. But a load of referrals I get are where that hasn't quite worked, and a clinician has said, I'm not sure why it's not resolving. And these little variants. Sometimes those crystals can get a little bit stuck, and there's some different techniques you have to use to try and dislodge them and get them flushed out.
Yeah, hence why you need ideally a specialist in most circumstances. BPPV is one of those that there are certain conditions. If someone comes in and it looks like presenting with that, I'm hoping it is that, because it's just quite straightforward.
Oh, absolutely.
And it feels like a miracle to the patient, doesn't it?
Yeah.
When they get the results.
Yeah. It's great. It's my favorite condition to treat because it's such a nice, it is really life limiting. People, I had a woman once, she refused to leave the house for 2 years because she found it so scary, but just anxiety creates dizziness, dizziness creates anxiety. And she just kind of, that had spiraled super out of control. Literally one treatment, gone, and you think, oh, poor thing, 2 years not leaving the house. So it can be, normally that's a rare case, but it can be just such a pleasure to take someone who's really suffering and say, right, I can do this now. What do you want to do tomorrow? Because you can do it. That's a great feeling.
Yeah. So Menier's.
Yeah.
What's that one? Because that's also quite a common one, right?
Yeah, Menier's is a horrible one. So Menier's is complex. We don't fully understand all the processes involved. There's probably many different ways it can occur. Menier's is going to be vertigo. So again, a true sense of spinning or movement. But the horrible part of that is you can have the acute hearing loss and tinnitus. Now, the reason Menier's is so horrible is these attacks can come on fairly spontaneously. So you could just be walking outside and then, I could be sitting here and suddenly the hearing drops in my right ear and I get really dizzy. The difference is the dizziness is going to last for probably about 20 minutes up to 24 hours. So it can be quite strong. So I could be out in public, suddenly have this 20-minute episode of vertigo or longer, up to 24 hours. But actually it's the hearing loss and tinnitus that really hurts people. So you can imagine, I had a musician once who was walking down the street and suddenly lost his hearing in his right ear. And often it comes back. So we think this nerve gets, this nerve kind of gets knocked out of action, but nerves are amazing. They can repair really well. So often you'll see this kind of sadly progressive hearing loss, but over a long period of time. But this poor chap had severe hearing loss in one go, and then it just never recovered. You imagine if your life is you're a musician and you suddenly lose your hearing in the right ear, then all you do it thinking is, well, I don't know how to sign language. I don't know how to lip read. If I go deaf in the left ear tomorrow, what am I going to do? So the problem with Menier's disease is we have a very high level of neuroticism, which these days we say neurotic. It's almost like an insult, but neuroticism is fear and anxiety. So it's not an insult; it's a kind of medical condition. So Menier's disease is a really horrible one. Now the problem with it is when we're trying to rehab things and recalibrate the vestibular system. So your balance comes from your brain using your eyes, your ears, and feedback from your body. So your brain is always saying, what did I see? But based on vision alone, you can't gauge movement. So if you imagine if you had a camera and you had the camera in this room and we panned it round to the right, when you're watching the video playback, you could say, okay, either the room stayed still while the camera span round to the right, or maybe it's the opposite. Maybe the camera stays still and the room span round to the left. Visually, they look exactly the same. Our brain has that times. Every single time I move my eyes, I move my head, my brain sees movement. But to understand, did I move, did you move, did we both move, we have to tune into what the ears and body felt. So if we have an acute episode of vertigo like Menier's disease, where the signal from the ear suddenly drops out, the brain says, I don't know where I am. So you start getting really, really spinning. Again, if both ears are always chatting, so my left ear is always saying I'm turning left, my right ear is always saying I'm turning right, as long as they're equal, I feel great. But if that left side suddenly drops out, the right side is saying I'm spinning right, and that's when you get that horrible sense of spinning. So that's what happens in Menier's. We get this sudden dropout. It recovers fairly quickly, but you often will see the slow decline. So what we start to see is over time, people have vestibular injury on one side. The difficulty is that when we're trying to recalibrate these systems by using eyes, ears, and body, if one system is prone to suddenly dropping out, it makes it much harder for the brain to recalibrate. So other conditions respond really, really well to vestibular rehab. Menier's disease, the research is not as strong. A bit hit and miss, depends on your own condition, how severe it is, things like that.
Does that generally mean it's not, it's just many people go without being treated, even if the best people are in front of them?
Yeah. So with Menier's, we really have to hit it with everything we've got. We have to look at your diet. We have to look at your sleep. We have to look at your stress. We have to look at your salt intake. You can't just rely on one. And a lot of people just reduce caffeine and reduce salt and then try to get on with life. I would suggest you try to look at everything. So although the research on vestibular rehab for Menier's is not great, it's still better than anything else. So we still need to do vestibular rehab. We still want to look at diet and stress and everything else we mentioned. But it's one of the rougher, out of all the forms of dizziness, that's one of the rough ones to have to live with.
Right. So we've gone from the easiest to the hardest, haven't we? What would you say is some of the top differences between BPPV and Menier's? How can you differentiate?
So the hearing loss and tinnitus will never occur with BPPV. So if you have any aspect of tinnitus, and again, there's different types of Menier's. So if you have any aspect of I get dizzy and I get some tinnitus or I get some hearing loss, then don't just assume that doing a repositioning maneuver is going to do it. That is definitely a condition you speak to a professional about.
I mean, hearing loss and tinnitus is always one side, or can it be both?
Typically one side. Typically one side. In theory, it can occur on both sides. There's no reason why it couldn't. But most people have it it very much. It's my right ear that always go.
And then infection.
Mm-hmm. So this is the nightmare one. This is the one you sometimes hear about music concerts being cancelled because the lead singer can't stand up out of bed. So basically you're going to have really aggressive, I say that normally you're going to have quite severe vertigo. So a real sense of spinning, again, because one ear signal has dropped out. So left ear, let's say, gets infected, hearing drop, vestibular system drops. So my right ear is now saying, hey, I'm spinning and nothing's opposing it. It's going to last from normally days to weeks. Classic history would be 2 weeks of severe vertigo, struggling, barely to lift your head out of bed, nausea, vomiting, really needing someone else to look after you, that kind of severity. It will then start to resolve and it will start to spontaneously recalibrate. So most people by week 6 are probably 90% better. So just going about your normal day, the brain is amazing and will start saying, okay, I recognize that left ear, it wasn't as efficient as it normally is, and it will start to recalibrate. So we have part of our brain called the cerebellum. Cerebellum is 10% of the total size of the brain, but more than 50% of the neurons. And its job basically is to sit between what the brain is trying to achieve and what's happening in real life in the body. So it's kind of like a manager hearing what the CEO wants to do and then looking at what the workers are doing in real life. And so the cerebellum is amazing because it sits between the ears, looks at one, looks at the other and says, oh, hang on, you're not saying the same stories anymore. You used to say the same thing. Okay, I'll just tinker with the inputs until we can bring them more into balance. I'll maybe pay more attention to what the eyes are saying, more attention to what my neck and feet are saying, and just get these things to level out. So with an ear infection, we have kind of two main types. We have vestibular neuritis, that's just dizziness, and labyrinthitis is dizziness plus hearing loss and tinnitus. Would sound a little bit like Menier's disease. With Menier's, no one's going to make that diagnosis until you've had multiple episodes. So the first time you have it, they're going to say it's labyrinthitis, and hopefully it is because that's not a big deal. The chance that you have labyrinthitis more than once is super rare. So if you have an episode of hearing loss, tinnitus, and dizziness more than once, even then, if you have it twice, 3 times, probably even then a neurologist or an ENT still won't diagnose it. They want, multiple 4 or 5 episodes until they start taking it more seriously.
So labyrinthitis is quite similar to Menier's. Why? So it's caused by an infection. Why does it affect just the? Because it affects. So vestibular neuritis affects the nerve going to the balance organ, right? The inner ear. Why is it just affect? Do we know why it affects just that nerve?
It's different. That's a really good question. So perhaps different types of viruses, or just luck. You have a bigger viral infection. So the way it works is we have the vestibular cochlear nerve. It literally means vestibular nerve and cochlear nerve, and they run next to each other. So they're coming just from 2 different apparatus. One that tells you about your inner ear, and the bit right next to it tells you about hearing. So they're right next to each other, and they join together, a bit like a wire in your house where you've got live, neutral, right next to each other, and they go back into the brain. So sometimes you just hit that first portion, which is purely vestibular, or it can bleed onto both. I said the word bleed. It's not a bleed. It's just like a viral infection, knocks out the nerve for a little while. So no, good question.
Yeah. Okay. And that one is good in the sense that it's the one that it will often resolve itself mostly.
Yeah.
Yeah. Is there usually much work that needs to be done afterwards, or do most people, they're good to go?
Most people can write it off as a horrible episode. I would say most people, 90% of the time, 6 weeks in, they're feeling much better. When people contact me in the first couple of weeks, I'll normally say to them, don't bother starting, don't pay for any rehab. You can start doing some basic stuff at home. We have something called the vestibular ocular reflex. So if I look at your nose, as I turn my head to my right, you see how my eyes go left. When I turn my head to the left, my eyes go right. So that reflex, we call it VOR for short. That reflex is so amazing. It doesn't matter where I turn my head, my eyes will stay on target. So we use that for vestibular rehab because we're using visual feedback from the eyes. We're moving the ears and we're moving the neck. That's going to all go into the brain and help the brain recalibrate. So when we're looking at that initial phase of recovery, we're going to give people some very simple vestibular ocular reflex. So just doing these nice horizontal ones. Well, we'll do 10. So generally aim for 10. So 1, 2, 3, making sure that vision is very clear, very sharp. There's no point doing this, feeling really dizzy and your vision's really blurred. And then we'll do up and down as well. And then we'll do a simple balance exercise. And we'll basically say to people, don't seek any more care for the first kind of 4 to 6 weeks. Just go about your normal day. The brain is trying to heal a nerve. It's using a lot of energy. You're going to feel fatigued. There's not a lot of spare energy for then doing rehab on top of it. The way I often think about it is, imagine you had a flood in your house and this room was ruined, but you were also trying to run a practice from this room. Very hard to do the decorating and treat people at the same time. It's a bit like that when you're recovering from an injury sometimes, that if you're trying to recover a nerve and heal the nerve, that's using quite a lot of energy. It's quite hard then to do rehab at the same time that a nerve is recalibrating. To recalibrate the dizziness, you need, we call it a tonic signal. So imagine sound waves. If the sound waves is doing the same thing every time, that's quite easy because the brain can adapt to it and learn what it's going to do. But if that sound wave is very erratic and you're getting all these different pitches, it's very hard for the brain to understand what the average is. So when the nerve is recovering, effectively what you're going to get is initially a very kind of muted signal, and then it's going to start building up. That's quite hard to recalibrate. So it's better just sometimes to go about your normal day, wait for that nerve to heal up 4 to 6 weeks, and then start doing the rehab once things are more stable.
And I assume you don't really have to do anything for the infection. You just let the body just go
viral. Yeah.
Just normal viral. Yeah.
Yeah. Okay. If it's bacterial, you'll have, it won't resolve so spontaneously. You'll have all the other signs and symptoms, much more dangerous. So you'll have fever, night sweats, weight loss, all that kind of stuff. You'll feel really unwell. Fortunately, those are very rare, very, very rare. I've never seen one. And when they do, you sometimes hear them hit the headlines because they go undiagnosed and then, tragedy. So super, super rare. Nearly always is going to be a viral infection. So it might be that you had a respiratory infection first, had a chest infection or a sinus infection, and somehow that made its way to your ear. Could just be it ended up there. You didn't do anything wrong.
So BPPV lasts no more than a minute. Menier 20 minutes to 24 hours. And then vestibularitis and labyrinthitis, how long do they typically last?
So you're going to say days to weeks.
Constant.
Yeah.
Yes.
Yeah, horrible.
Okay.
Yeah.
And they're quite similar in the duration on those two. Yeah. Okay. So what about then the more functional types? Am I right in saying that they are probably the most underdiagnosed?
Yeah. So the big one really is a condition called triple PD, or 3PD, you'll hear it referred to. So it's persistent postural perceived dizziness, or persistent postural perceptual dizziness. And basically, if we break that down, it means that it's persistent. It keeps going. So for diagnosis, it's 3 months or longer, present for most days for 3 months or longer. Postural is that when you're upright. So you could lie in bed or lie on the sofa, your symptoms resolve. So people wake up in the morning, lying in bed, think, I feel great. They get up. Once they have a shower, get dressed, make their way down into the kitchen, then the dizziness starts. And it's perceived. You perceive that you're unsteady. But when we do assessments on your inner ear, they take an MRI, take a CT scan, they do calorics, where they put like warm water into your ear, or do vent tests, other types of testing. It's all normal. So you perceive you're unsteady and you don't feel right, but when we do medical exams, it's all normal. So it's called a functional disorder. It doesn't mean it's made up or it's in your head. It's 100% real, but it's like a computer. The hardware looks great, but the software's not working. And that's basically what happened.
So they'll probably get, well, when they're examined by the medical profession, they'll often think there's not a lot wrong, or at least they can't find anything wrong. But so what is it that you're doing different?
It was massively underdiagnosed. It's often misdiagnosed as anxiety. So it's often just chalked up to anxiety. So it's, you've had a stressful time, and people have, it can be caused by stress. So it's going to typically be caused by medical conditions. Vestibular conditions is often classic. So you could have vestibular migraine, BPPV, vestibular neuritis, and that leads to triple PD. So the reason that happens, again, your brain uses your eyes, your ears, and feedback from your body for balance. So if we have something that disrupts the feedback from the ear, the brain has to use vision more. We're very visual. The human brain is very visual. If you look at different areas of my brain, it's basically geared up to processing what can I see now, or moving my eyes to a new target so I can process something else. So either I want to stay engaged with something and kind of stay connected with it so I can understand it more, or I can say, okay, I'm bored with this and I want to jump my attention to something new. So that's basically what our brain is always doing. If we lose that input from the ear, the brain has to use vision more. The brain's very good at that. That's a perfectly normal short-term adaptation. The problem is in triple PD is you continue using vision for balance. And as we said earlier, every single time you move your eyes, your head, your brain sees movement. It can't use vision alone to understand, did you move? Did I move? Did we both move? And so as a result, every time I move my eyes, every time I'm in a busy environment, I'm in a supermarket, people crisscrossing, when you've got lots of vertical lines, horizontal lines, bright lighting, colorful packaging, I'm going to get a sense of acceleration. So we're surrounded by optic illusions, tricks of light, color contrast, depth perception. So if I'm using vision only, every time I move my head, my brain's going to have a sense of acceleration, and that doesn't match maybe what my neck felt or what I am getting from my ears felt. So your brain senses, well, hang on. Those guys said we moved 20 degrees a second, but my eyes are saying they saw 40 degrees per second of movement. Where am I? So triple PD is horrible because you feel really scared and anxious. Actually, the chance you fall over is very low. The people with triple PD don't fall over. People with Menier's disease can fall over. People with acute labyrinthitis can fall over. But people with triple PD actually don't fall over. Yet they have this real fear of just feeling constantly unsteady. A bit like if you've ever been motion sick, like on a boat, that's kind of like the feeling. Or one of the descriptions I like is if you've ever seen an escalator that's not moving, it's not moving, and yet when you step onto it, you still have that little sense of movement. That's kind of what it's like to have triple PD all the time. So every time you move, every time you have this little jerk of movement, and it doesn't quite match what really happened. So triple PD is really devastating. Part of the diagnostic criteria is that it causes significant impairment and functional distress. So these are people who retire early, have to take prolonged periods of absence from work, feel like they can't look after their family, don't want to play with their kids, it really limits your life. It's a horrible one. And that's one of the ones I have a great passion for treating. So I'd say probably the two areas that I've really worked on and have really focused on has been vestibular migraine and triple PD, both because they're both underdiagnosed. They have a huge impact on people's lives. They are absolutely treatable, but it does take quite a specific program.
The other three that we went through are very much with the inner ear. Is the inner ear involved with this one?
No. So you could have something that affected the inner ear initially, but it's probably healed by now. So you have an infection that's totally healed up, totally normal. So imagine if I broke my leg and I'm using a crutch to walk around. That's a normal adaptation. But once the bone is healed, the muscle's all good, I should throw away the crutch and get on with life. It would be maladaptive. It would be a bad adaptation if I carried on walking with that crutch or feeling that I had to have it. That's basically what's happening in triple PD is the adaptation was you use your vision more, totally normal, good adaptation. But now the ear's healed up, you should stop using vision so much and start using that team again. And instead they're still walking around months later, still using vision too much. It's a maladaptation. It's no good for you. So what we have to do in rehab is try to train the brain to integrate those three systems and be able to shift between them. So if you're walking outside and it's a lovely sunny day, when you step into a dark room, you know how you can't see much. So what your brain should say is, cool, I can't see very well. I'll just listen to my ears and body say more. And then once vision comes back, great, cool, we'll use all three. Or if you're standing, if I was having to do a balance test with you and I had you stand with your feet together, we say eyes open, you got all three systems. If I say eyes closed, cool, we've lost one, but the other two should still be strong. So your balance shouldn't really change that much. Maybe a very slight sway. But what you'll see in triple PD and other conditions where people are using vision too much, we call it visual dominance, is you'll close their eyes, straight over. So the brain is using vision so much. As soon as you shut the eyes, it says, I haven't got a clue. And over you go.
So it's essentially a faulty adaptation. Yeah, that makes sense. And that occurs in the brain predominantly. That's linked with the eyes and the neck.
Yeah, so we call it a central vestibular disorder. So central being brain-based, basically.
Okay. So if there's certain conditions, you can do an MRI and you'll see like something in the brain. So this is obviously not the case with this condition. What is actually happening in the brain to cause, like when you say adaptation, what is actually happening physically then in the brain, even though we can't see it?
So it's that visual dominance. So the visual dominance means that the way you're perceiving movement is not quite matching up to what your body's actually doing. And at the same time, that dizziness, that unsteadiness is going to create anxiety. So falls are one of the leading causes of accidental death and injury worldwide across all age ranges. So over the age of 30, 30% of 60, over the age of 60, 30% of 60-year-olds are going to fall each year. Over the age of 80, half of all 80-year-olds are going to fall each year. That has always been the way. So if you take car crashes and motorbike accidents out of the way, falling is the number one accidental cause of death and injury worldwide, of serious injury worldwide. So we know deep in our bones that falling over is very dangerous for us. So when we feel unsteady, it's an absolutely reasonable response to feel quite anxious. So muscle tone increases. That's why we get neck stiffness and back pain in the majority of people with chronic dizziness. Muscle tone increases. So if you and I were standing in a pub and some big guy was going to come and flatten me, I wouldn't be lovely and relaxed and say, go for it, and just have him throw me on the floor. Hopefully I'm going to tense up and try not to fall over. It's exactly the same with dizziness. If you don't feel steady, of course you're not going to be relaxed. You're going to tense up all the time, trying to hold that spine rigid and keep yourself safe. At the same time, we're going to see changes in blood pressure, heart rate, pain. When you increase muscle tone, going through all your muscles are going to be these little fine nerves that give you to get to the skin, to give you sensation to your skin. So any part of your body you can feel, it means that a nerve has managed to go through tissue to get there. So if we increase muscle tone a lot and it's constant, you're going to start squeezing these little peripheral nerves. They start to become hypersensitive. So now when you touch someone with dizziness, their shoulders, like, it's so sore. Headaches, jaw pain, you see a lot like this all the time. So the brain is basically learning that you live in an anxious, scary world, and it's having the same response as it would if you let a poisonous snake into this room. We're not going to be loving and relaxed. We're both going to be tensed up and worried about it. Exactly the same.
And how long does the dizziness last for then?
Triple PD is horrible. It can go on forever. So you're going to see it's typically worse with stress. It's going to be worse. And when I say stress, I mean in the broadest sense. So that could be you have a medical condition, you have family stress, house stress, work stress, you have chronic pain. So some people might have had chronic back pain and now they start to get dizzy. So it's a really horrible one. The condition is diagnosed with a minimum of 3 months. Totally normal to see someone who's had it for a year or 2 years.
And that's constant?
Most days.
Most days, yeah.
So if you have good times, times get a little bit better, you might say, actually, I actually had a really good week. So you have this kind of most days kind of waxing and waning. So classic history would be, I get up, had a really horrible morning. Lunchtime I came home, lay on the sofa. Symptoms were much better, almost resolved. First couple of hours back at work were okay. Then I got that horrible email and my symptoms spiked again. So it's going to be like that most days for 3 months or longer. But in terms of how long can it go on for? Until you get better. But you absolutely can get better. It's not a lifelong diagnosis. We can absolutely resolve it. So for me, I have a kind of 3-month program with it. And we normally see that over the 6 weeks, you see some improvements, but nothing significant. In the last 6 weeks, that's when you start to really see some great changes. So for me, it's normally about week 10 that people start to say, I'm going back to work now. I'm coming out of retirement, that kind of stuff.
Does it ever resolve itself?
Absolutely. So it can get better itself if stress goes down. So, sadly, if you've had a sick parent or something like that, you're caring for them and then they die and then things get a little easier, life gets a bit easier, you kind of move on. Absolutely. As that stress comes down, dizziness comes down. As dizziness comes down, stress comes down. Absolutely, it can resolve.
Is there anything that we can do then to stop these things from coming on in the first place? Any preventative things to be aware of?
It's really hard to predict who's going to get it in the first place. So the vast majority of people will have dizziness and not develop it. Education is probably the biggest thing. So understanding why these things are happening. Fear is a big part. So when you have that first adaptation of using vision more and you start to feel unsteady when you go into a supermarket, in a cafe, in a supermarket, understanding that process and just thinking, okay, I'm using vision too much while my vestibular system recovers. This is totally normal. Is probably part of it. If you think this is really weird, I feel spaced out all the time, I feel lightheaded and unsteady, and I used to be able to go around the supermarket fine and go to work fine and get on the tube fine, and now I hate all of it, and you start limiting your life, that probably is where these things go bad. So it's a real kicker, right? We know being social is really important for your health, for your mental health. So if you don't feel that you can go to the pub to see your friends, or you don't want to go to the restaurant to see friends, or you don't want to go on holiday because you're worried the flight will be so bad, you start limiting your life, and then all these things start to, your general well-being goes down.
You mentioned earlier that vestibular migraines, they don't always present with a headache, which may surprise quite a lot of people. What is happening there, and how does that look different to triple PD?
So vestibular migraine, a bit like ADHD and autism, that we've seen an explosion in diagnosis over the years, and there was a big worry of like, why has now everyone got ADHD and autism? Like, where is it all coming from? What's causing it all? Actually, probably a lot of it is that it's been massively underdiagnosed forever, and finally we're getting better at recognizing it and taking control of it. It's like that with vestibular migraine. So classically, we say BPPV is the most common cause of vertigo. Every time they do more research, vestibular migraine goes up and up and up. So now vestibular migraine is kind of challenging for the throne. It's going to hit about 1 to 3% of the population. It's a lot, 1 to 3%. So the difference with vestibular migraine is it's more sense of dizziness, vertigo, and there's lots of, you name a type of dizziness, that can be vestibular migraine. So it could be head induced. So I turn my head and then I get dizzy. The difference is it's going to last for a minimum of 5 minutes up to 72 hours. So with BPPV, I turn my head and go, oh, well, I'm dizzy. And then it settles within a few seconds. With vestibular migraine, it could be the same. I turn my head, get dizzy, but then that dizziness is going to persist for a minimum of 5 minutes, classically 20 minutes, an hour, but it could in theory be up to three days. And the kicker is it can take 2 to 3 weeks to recover from one episode. So with vestibular migraine, you can have these acute episodes of vertigo where you really do feel like you're moving, and then you're going to subside into constant sense of unsteadiness, a bit like triple PD. So they can look similar. You can have both. You know, vestibular migraine, we have these acute episodes, but when you're not having them, you've got triple PD. And that's a lot of the patients I see is we have this horrible combination of both. So in vestibular migraine, what we're getting is a bit like a migraine, you're getting hyperactivity. So what's typically happening is either in the peripheral system in the ear, or more centrally in the brainstem or brain, we can get hyperactivity of those balance networks. So now instead of my left ear not working, it's working too much. So I get a sense of dizziness, spinning, falling over, being pushed down to the ground. So the main symptom is dizziness. That could be vertigo or unsteadiness. You might have half the time light sensitivity, sound sensitivity, headache. The headache will be moderate to severe. So it's going to be that throbbing, pounding headache like a migraine, typically in the eye, around the eye. Occasionally it can be more occipital, back of the head. Nausea, vomiting, and all that kind of stuff. So it's a complex beast.
Yeah, and a lot of the different ones we've gone through, they overlap a lot, don't they? So you can really see why it's quite confusing to really tell the difference between all of them.
So what I would say is people who are Googling these things, it gets very confusing, very upsetting, because you'll be reading all the different accounts. You'll be going on Facebook, reading people's things, and you'll start thinking you have MS or something like that. The diagnostic criteria we use have been worked out by super clever people looking at thousands and thousands and thousands of cases and drawing these together. So we have very distinct criteria for different conditions. So you want to see someone who knows those criteria, can take you through them. The thing that always upsets me is I'll occasionally hear someone where their history is perfect for triple PD. They meet absolutely every criteria point, and then maybe go to see another healthcare professional. They'll say to them, hey, sometimes we will prescribe or ask the GP to prescribe SSRIs. They can be helpful in triple PD sometimes. So if someone's got a lot of anxiety, they're really struggling with the mental health side of things, sometimes SRIs can be useful in the short term to help break that anxiety dizziness cycle. And so occasionally you get someone who will just say, oh, I've not heard of triple PD. They'll literally type Google triple PD, have a quick read of it and say, oh no, I don't think that's what it is. I think it's just, I don't know what it is, but it's not that. that's so destructive to someone who's trying to get better from it, because doubt feeds that fear, feeds that anxiety. So I'd say only take advice from someone who really knows this subject. Only take exercises from someone who really knows the subject. Don't Google it. Don't. The problem with triple ED is if you do a bunch of exercises, generic exercises that are very visually based, things that involve like a lot of saccades or a lot of pursuits, you can make your triple ED worse. So you really have to nail this and not just go for generic advice. Vestibular migraine, similar. There's a lot of misinformation around. There's a lot of misunderstanding around. So you really want to understand what is the process involved and what do you do about it? You personally, because you will be different to that person over there.
Yeah, and it's amazing how each person does present very differently, don't they?
Oh, 100%.
Despite having the same condition.
Yeah.
So rehab seems to be quite a key theme here in regards to the treatment of pretty much all of them, right? Yeah. You have an app for this, right?
Yeah.
Can you tell us more about the app?
Yeah, so the Well Balanced app. So it's Well-Balanced. It's a vestibular rehab app, particularly focused on triple ED and vestibular migraine. Vestibular neuritis as well, but the vast majority of users have vestibular migraine and triple ED, one or both those conditions. Some people just have motion sickness, some people just have visual dominance, but the majority, those kind of categories kind of blend very well with those two main conditions. So there's a free week that anyone can try. Each day there's a dizziness assessment, some lessons on kind of why you feel dizzy, some of the stuff we've been discussing today, really, and then some fundamentals. So in the first week, you can do some basic vestibular rehab. Depending on your condition, it probably won't be enough for those more complex conditions, but it is the fundamentals. And then what I'd go through with everyone is if people want to go on to the 12-week course, they always have a call with me. So a video call, we'll take a history, make a diagnosis, talk about treatment options, and then if you're suitable, you can go on to the 12-week course. But super, you do dizziness assessments at the beginning, at week 4, week 8, and week 12. So we have all the data from all these people, and we know, we've got really great numbers on it now. But it took a long time to get there. So this has not been something we just slapped together. It's been, in terms of learning how to treat vestibular migraine and triple ED successfully, it's taken years and years. And to get the app to the phase where we can do it remotely. So people would have a weekly phone call with me. So every week we do either individual or a small group. And you have a weekly phone call with me to make sure that it's still tailored. And at various points in the course, you'll do a test. And if you go this way, the exercise take you this way. If not, we'll go this way. So yeah, it's great. I love it. It's really nice to be able to work with people kind of all around the country now, and people who are stuck at home and can't travel to the clinic. That's how it started. So during COVID, no one could travel. Started treating, I'm sure like you did yourself, started doing video calls. And I found that my Disney patients got better just as well as they did as if they saw me in person. Then a bunch of research came out at the time and said that vestibular patients did just as well remotely as they did in clinics. And so it's like, great, we got this confidence. And then it was just about putting these programs together, fine-tuning it, and doing these progressively challenging exercises that are time efficient. Because that's the problem with vestibular rehab in the past. It's, here's an hour's worth of exercises. Do you need to do it 3 times a day? Like, how do you do that when you've got kids and work and a house? It's just not possible. So instead in the app, you'll do a lesson trying to help you understand your world a little bit more. And then kind of 5 to 10 minutes in the morning, 5 to 10 minutes in the afternoon.
And that's what I love about the fact that you got that app, because we can speak, all about the different types of dizziness, and like particularly the functional ones. It's going to be quite hard for people really to find someone near them where someone actually understands that and that can actually treat that effectively.
Yeah.
So the fact that they can actually go onto an app, do that in the comfort of their home is really brilliant.
Yeah, and still have human connection. So it's not just a faceless app you could just kind of like on your own trying to hope it do it right. The technique on these things is really important. Yeah. So like we said earlier, if we're doing this kind of VOR exercise, there's absolutely no point just whipping my head back and forth. And yet if you go onto YouTube or you're given a sheet of paper, it will say, turn your head as fast as you can. Well, that's a waste of time. So what we'll do is watch you do the exercise and say, how are you getting on with it? Okay, no, not right. Do it slower, do it smaller. Or, fantastic, we're going too slow. Increase the speed, increase the amplitude.
And success rate?
It's fantastic. So we have what are the numbers? I don't want to make up numbers for you, but the vast majority by 12 weeks are doing fantastically. With triple ED, we will say that it can take longer. So I say to people, there's give me 4 months is what I say to triple ED. Now, normally by 12 weeks, their score will have dropped from severe all the way down to mild. So in the dizziness handicap index, it's a score out of 90. Most people will be starting above 60, which is really bad. That means you're you'll feel much worse in just around the house. You feel like you're limited. You're not able to socialize. You can't do exercise, all that kind of stuff. The vast majority would have dropped all the way down to like 10 or 16, which basically means they're back at work doing normal things, but they will still notice in certain places they get a little bit unsteady. That's basically what you'll bet at the end of 12 weeks is normally either life is great, or you'll say something like, I'm great the majority of the time, but when I went out and had a few beers, then I noticed it again. Or we got a baby at home, had a really bad night's sleep, next morning noticed it was a bit unsteady again. But that's a world of difference from I don't want to interact with my child because I feel so awful. Other conditions, vestibular neuritis, we got 100% success rates, BPPV, 100% success rates, vestibular migraine, again, can be tricky, but vast majority of people are doing phenomenally well. So on the app, we're realistic with it. We have a money back guarantee on it. So if people aren't better at 4 months, then the course hasn't worked for them, they can have a full refund.
Well, okay. BPPV, you can treat through the app?
We will, it depends if they're, so normally I'll suggest they come and find someone local. So normally we'll have a screening call. So normally with BPPV, what I'll say is, it sounds like BPPV, let me have a look and find who's local to you, because it's just much better if someone can do it hands-on for you. But we have people who are living in remote parts of Scotland and stuff like that, and there is no one there. So then we'll say, okay, here's the video on how you do it. And ideally we'll do it with me. We'll have one person filming, one person doing treatment, and then I can tell them, hold the head, don't let them move, don't let them lift. So yeah.
Okay. Yeah. Quite the skill to do it through a video call, isn't it, compared to when you're in person, but at least then you're reaching more people. So that's really, really good.
So the problem with chronic BPPV is you get that same visual dominance. So that's sometimes why we need to do a full rehab. So you can, even though you can get rid of the acute vertigo, some people still get up and say, I feel much better, but still feel like I'm floating on my feet, still feel a bit spaced out. And that's the case where we say, okay, let's rehab it properly.
Okay. Because you can do the positional, but you may need some rehab on top. Yeah, that does make sense. Perhaps we can end by just going through some things to be aware of. So people may be trying to self-diagnose themselves if they're kind of hearing the different ones, but are there any symptoms where you would say, go to hospital?
Yeah, absolutely. So the scary one. So if it's the first time you've had acute vertigo, so if you really feel like it's the first time it's happened, don't just sit it out at home. Definitely speak to a healthcare professional. So get 111 is a great resource. So if you they're really good at kind of screening for the scary stuff. So if you have acute dizziness, always ring 111 and just say, let them know what's going on. But particularly if you have anything that's like, you notice your speech goes, you can't swallow, you have a drop attack. So that's where you like literally fall to the floor. So if you can't speak, you can't swallow, you drop to the floor, or if someone's with you and they notice strange things like your face has changed, or you can't move your arm, you can't move your leg, anything like that sounds like stroke, that's the way to go. If you see that you might not see it, but if someone sees that your eyes are bouncing around your head, like I saw with my wife, that is a skill. You need to be able to tell different eye movements, tell you about what's going on. So I could tell, it's not a stroke from the eye movement, but you could also tell, it is a stroke from the eye movement. So you always speak to a professional if you get any movements in your eye or anything like that.
Okay. Yeah, that's good. But my final question, maybe a little bit less linked, but maybe linked with what we've spoken about, is, are there any health habits that you do day to day to keep yourself well generally?
Exercise probably 5 times a week, and I keep it varied. So as much as I'd like to say, I love climbing, I love rock climbing. So part of me wants to be just a beast in climbing, but I recognize that climbing is very stressful for your fingers. And I am a chiropractor. I don't want injuries and tendon injuries and arthritis in my hands. So I would say one of my great pains in life is I'm a jack of all trades when it comes to sport. So I like running, but I don't love running enough to do it crazy amounts. But the advantage is it probably means it will save my knees. So I think in terms of health, variety is the spice of life, and variety is one of the keys to health. So it doesn't matter how great you think cycling is, you should be doing a variety of things to keep yourself healthy. So I do resistance training a couple of times a week. I go running a couple of times a week, and I like to try and go climbing. And I think being social is a huge part of it. So the more social interaction, the less news you watch. We all know the news is, if a new product came out tomorrow and we said, hey, it increases your rates of anxiety, depression, increase the chance you're going to start smoking, it's going to increase your chance of having to use antidepressant drugs, you're going to start drinking more alcohol, you're going to start sleeping less. Do you want it? Everyone would say absolutely not. But that's what we know the news is all about, that focus on things. So I think keeping a close grip on where your attention is and what you allow in is probably a pretty important part of it.
Yeah, variety is also quite an important thing in investment as well.
Yeah.
So,
well, that's one of the big things I think is compounding is key to everything. And I think compounding when it comes to your health is a huge part. So rather than doing fits and bursts and thinking, right, I'm going to join the gym, doing it for a few weeks, dropping out, I'm going to eat healthy, I'm going to start having kombucha and kefir milk, and I'm going to do it on a ketogenic diet, and you do that for a few weeks, be probably better just to do some good things consistently every day. And you'll probably see huge health benefits compared to doing the fad stuff, taking the new supplement that's going to make you live forever. Just eat well consistently.
Yeah, it is unfortunately as simple as that, I think. Like there's a guy that, I don't know if you heard of him, but he's essentially trying to live forever. And, but I think his philosophy is just quite crazy in my mind, but some of the things is quite interesting that what he's doing, and really what he's doing is eating well, sleeping well, exercising, like all the basic stuff that we already know. I don't think it's going to be a super pill that's going to make us live forever. I think essentially you just got to live well, and it's those small things. So I like that. Thank you so much, Jake. That is hopefully really, really helpful, or it definitely is very helpful for anyone that's just trying to, as you said, you had a patient that was dizzy for 2 years. So a lot of these people just don't know where to turn after maybe they've had some failed attempts with certain practitioners. So hopefully that gives them an idea. And what I love about this is that you've got an app that people can go to. Completely guide people that way if they get on the issue, particularly with the functional stuff, and the fact that they can even talk to you. So even if they don't have more something that your app can help them with, then it should help them, guide them in a better direction.
Yeah, point them in the right. That's exactly it.
Yeah,
exactly it. We just want to help people find answers. That's great. Fantastic. Thanks so much for having me.
Thank you, Jake.